Stay tuned as the doctors scope colon issues on call. Funding for on-call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support on-call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation. From Crohn's disease to irritable bowel syndrome to colorectal cancer to hemorrhoids, a lot can go wrong with the colon. Regular checkups and that dreaded colonoscopy save uncounted lives each year. We scope the colon when the doctors are on call tonight.
This year there will be 1 million people worldwide who will discover they have colon cancer, and eventually 1/3 of those will die from it. Tonight we'll learn how colorectal cancer might be prevented or discovered early and how to treat it if it happens. But there are more issues than cancer that involve the colon and rectum. Tonight, from the privacy of your living room, you can ask and learn about rectal issues such as fissures, hemorrhoids, rectal pain, itching, and bleeding. And we could discuss colon topics such as diverticulosis and itis and ulcerative colitis and Crohn's disease and new and old ways to approach such conditions. But we cannot know what you need to know without your questions. Indeed, this territory of the rectum is not usually a topic about which people are comfortable talking, but your questions come to us without a face. You are incognito. There is no question that can embarrass you, just us. Now is the time to get the answers to such private questions. Call or email us from our website, whichever you prefer. With us tonight to answer your questions are Dr. Scott Baker from the Surgical Institute of South Dakota in Sioux Falls and Dr. Eric Rolfsmeyer from Sanford Surgical Associates in Sioux Falls. So, Eric, tell us a little bit about you. Where are you from originally?
Grew up in Nebraska, Lincoln, Nebraska, but have been in Sioux Falls, South Dakota since 1983.
You went to med school?
In University of Nebraska. Did my surgical residency up in Minneapolis and also did the colon rectal part of my training in Minneapolis. So.
And you've been in, you said Sioux Falls since when again?
83.
Okay, so, well, and thank you for joining us for tonight's show.
Glad to be here.
And Scott, you're from where originally?
Sioux Falls.
You're a Sioux Falls boy.
Yeah, Sioux Falls.
And you went to what school, undergrad, and then med school?
Yeah, I went to St. Cloud State University, and then medical school at the University of South Dakota. Did my general surgery training out at a place called Guthrie Clinic, which is out in Pennsylvania, and then colorectal fellowship training at Ohio State in Columbus.
So the two of you are, I mean, how many colorectal surgeons are in the state of South Dakota?
3.
There's another one in the hills.
No, my partner, Matt Cheddar, joined our group a couple years ago. So.
Okay, so there are 3 colorectal surgeons. So the difference between a general surgeon who does general abdominal surgery and a colorectal surgeon is what? How would you say?
Well, a colorectal surgeon has gone on to train additional training in the field of colorectal surgery. It can be a year or 2, and then for the most part, specializes in that area. General surgeons do. We overlap some with general surgeons, and there are general surgeons obviously in the state that will do a fair amount of colon surgery. But I think there are some diseases that are a little more complicated and a little more unique, and certainly we get into those areas.
Those areas, you know, the rectal colon cancers that are closer to the rectum, that's a little bit more difficult. Scott, your partners send those to you? Is that how that goes?
Yeah, I think as a general rule around, in my group around the state and even in the network I'm part of, that most of the rectal cancers come to me, and mostly because it's a difficult area to work in. You need to be specialized and sort of understand the anatomy and the disease process down there.
Yeah, I mean, that's because the drainage is so much, I mean, the lymphatic drainage, the spread of cancer is more complicated. All the nerves that involve the pelvic region and the sexual function and all that. Would you put it any differently?
No, I think you hit it right on the head there.
Yeah, that about right? Okay.
That's right.
Yeah.
So, but we're going to talk about colon cancer, and I think that we'll start out with that. The issue of colon cancer is only so good as it's discovered. And so colonoscopy is really one of those things that opens the door to making that diagnosis early. I was trying to find the data about if you did a screening colonoscopy and found colon cancer versus wait until a person has symptoms. How many years is that, and how much of a difference does it make for chances of success?
Well, if you're going to wait for symptoms, a lot of times you waited too long, and a great majority of the cancers and the patients we see with colon cancer, they don't have any symptoms at all. And if the cancer's a little more distal in the rectum and the
closer to the distal, meaning nearer the rectum.
Right. You might have some bleeding, some change of bowel habits. But if the colon's further upstream at the start of the colon, frequently you're not going to have any symptoms, and for many years. And you know, not uncommonly we'll see patients that the bowels are the same, they're not noticing any blood, and the only thing we might notice is their blood count's dropped a little bit. But if you know, they might not even notice that. So you know, that's why colonoscopies are so important. You know, it's a disease where we want to pick it up way before
they start having symptoms.
Right, you have symptoms.
Right, so screening colonoscopy versus a colonoscopy for symptoms or for prior polyps or for family history or whatever, there's a difference, the screening. What about screening colonoscopy, Scott?
Well, I think Eric hits the nail right on the head that most of these, 85, 90% of these are asymptomatic. People don't have any symptoms, and that's the importance of this, is that they need to get that screening colonoscopy to find the polyps early before they become cancer.
Yeah, right.
That's the issue, is that the polyps, there's roughly 25% can become cancer. We just don't know which 25% those are. And that's the problem. So if you can get there early and get those before they become cancer, that's the key.
So, and so the first screening colonoscopy should be when?
For an average risk person, age 50.
And what would make you a higher risk person?
Family history would be one. You know, if you had a first degree relative, mom, dad, brother, sister with colon polyps, colon cancer, you'd be at higher risk. Certainly there are some diseases, ulcerative colitis, you're a little higher risk, to some degree Crohn's disease, but I think family history is the most important one.
Anything to add?
No, I think that's true.
All right.
Yeah.
What?
Well, I think what's important, and I think, I'm not sure everybody understands this, but cancers we feel start as small growths called polyps, and they'll sit in the colon for 8 to 10 years at a benign state, and then they'll eventually turn into a cancer. And so it's an ideal cancer to screen for, because it's going to be benign for many years. If you come in and have your colonoscopy, get these benign polyps taken out, you pretty much remove that as a problem for yourself. And so that's why it's so important to have the screening colonoscopy done.
perfect takeoff on this. According to cancer.gov, there are over 1.15 million people living with colon and rectum cancer in the United States, and the best way to increase their chances of survival by early diagnosis is with regular colonoscopies.
We usually start screening at 50 years old for people who don't have any symptoms and don't have any family history. Any family history of colon cancer, usually we recommend, if it's in a first-degree relative, we would recommend every 5 years. There are diagnostic colonoscopies as well as surveillance. Surveillance is when it's less than 5 years, but they've had something such as colon cancer or colon polyps that need to be monitored. And then a diagnostic colonoscopy is for people who have problems such as blood in their stools, black tarry stools, change in their bowel habits, abdominal pain, diverticulitis, something like that. That makes us, that there's something specific that we're going in to look for. Abnormalities can be anything from masses to polyps, as well as diverticuli, hemorrhoids, I would say. Even though they're really, really common, they are still an abnormality. There's also arteriovenous malformations, meaning abnormal connections between blood vessels. I've found actually quite a few lymphoid aggregates that look like polyps, but we still remove them anyway because we can't tell microscopic, we can't tell just by the naked eye necessarily. Any blood and stool should not be ignored because no matter what age you are, colon cancer can occur at any age. And I know of 30-some-year-olds who have died because, you know what, they just thought it was hemorrhoids. The biggest deterrent for people not having colonoscopies is really the prep. Whenever I've talked to a person, they say, I just don't want to do that prep. I just don't want to do that prep. The prep lasts a night, and yes, it is not fun, but the things that we can prevent from doing one prep is just, we can save lives doing colonoscopies. You could go through the prep, have a colonoscopy, take off polyps that could go into cancer, and that could prevent you from having to have a surgery, which would decrease your time at work, and you still need to go through a prep then.
Join our conversation by calling in your questions at 1-888-376-6225 or send us an email at questions@oncalltelevision.com. We need your questions, 1-888-376-6225. And we already have some questions. And thanks to Joanie for volunteering to be the person getting that colonoscopy, sort of the Katy Couric of Brookings, my lovely wife. And doesn't she have a lovely colon, wouldn't you say? We have a call from Sioux Falls. Are flat polyps in the colon rare, and are they more dangerous? Are they less dangerous than polyps out on a stalk?
There's actually been some controversy over that. There's been some papers that have come out discussing the flat polyps and does colonoscopy make sense or not make sense to do, and are we missing a lot of polyps? So I think that in general, flat polyps are more problematic because you may miss them as you go through with your colonoscopy. You may slide right past it and not see it, where ones on a stalk are a little easier to see. The other issue with the flat polyps is they tend to be more on the right side of the colon and are a little more difficult to visualize and even deal with over there, which is where some of this controversy comes in.
Yeah,
I would agree.
One article said the flat polyps have a higher risk of adenoma than the other polyps. Now, I know that the hyperplastic polyp is about 50% of them are adenomatous and 50% are hyperplastic, at least in my experience when I counted. And the hyperplastic are quote unquote not dangerous, but I've seen tons of, well, not tons, but a number of hyperplastic polyps that are surrounding cancers. And so I think that I take them as a potential risk. What do you feel about hyperplastic polyps, you guys?
Well, that's changed over the years, and we used to think hyperplastic polyps had no malignant potential, but the larger, flat hyperplastic polyps, and even the terms we use to describe them, we call them more serrated adenomas and that sort of thing, but the larger, flatter hyperplastic polyps do have a malignant potential. They do need to be removed, and as Scott said, they're oftentimes very subtle and they're easy to miss. The hyperplastic polyps, the smaller ones in the rectum, aren't thought to be a problem. But when you get more proximal in the colon, they're flatter.
Right.
They do have a.
You can see a lot of these little hyperplastics near the rectum.
Right.
They don't seem to be the dangerous ones.
Yeah.
But when they're on that right side, way over here, up near the cecum, the far end of the cave.
And they, a lot of times are flesh colored, the same color as the mucosa of the lining, which makes it more difficult to identify also.
Yeah. We're talking doctor talk. The point that people need to realize is that the doctors need to take their time, do a careful colonoscopy, and look for all kinds of polyps, flat or on a stalk. Here's a caller from Pierre, has diverticulitis and has been told not to eat peanuts. Is this still the recommendation? What's the take on the diet for diverticulosis?
Well, that's a great topic, because I see this in my office on a daily basis. People come in and say they've been told they can't have peanuts or nuts or any of those sort of popcorn, and they love it, and of course they can't have it. There's really no data to suggest that. So I think usually when I tell people that, they look at me like I'm crazy. Yeah. And it's tough to sort of turn the wagon around on that. But yeah, there's no good data. There's never been any good data to suggest that. So
I mean, why do people get diverticulosis? Some say that there isn't enough fiber. I mean, the popcorn and the nuts and all that is fibrous. I mean, it's quite high fiber. Mm-hmm. There's not enough fiber, then that's why they have diverticuli. I mean, or is it just inherited? Eric?
Well, I think it has to do with our diet in the westernized countries, which doesn't have enough fiber in it. You know, parts of the colon, in particular the sigmoid colon, the peristalsis may be not coordinated. And
peristalsis is the squeezing, like the toothpaste, pushing.
Right. And there may be some high pressure zones that over years cause these little diverticuli to kind of, just like a weak portion of the tire, it just kind of goes through the muscle. The inside lining just pops through the muscle of the colon wall and forms these little pockets. And you see them, and Scott sees them when we do colonoscopies. We see them all the time. And what happens is one of these little things ruptures and causes little infection, inflammation, and then you get pain, usually in the left lower quadrant. And that's what diverticulitis is.
Yeah, it might be worth taking a second just to sort of distinguish the two. I know in my office I see a lot of people say, well, I had diverticulosis, therefore I need my colon out. And it's really more, diverticulitis is the inflammation of the colon, or as Dr. Rolfsmeyer said, the breakage of that pouch that pouches out. That's really the issue. A lot of people have diverticulosis. In fact, most of the people, if you look at their age, you kind of say that roughly that percentage of people has diverticulosis.
Yeah. Osis is the presence of, itis is inflammation. So they get inflamed from whatever reason. It's certainly not the popcorn.
Right.
We have people eat popcorn and high fiber diet. There is a question that I get commonly about, well, what can I do about polyps? I mean, what is the one thing that I can do about polyps? And the New England Journal suggested that it's aspirin. There's a number of studies, and then the studies that comparing what dose of aspirin. Two of them back to back said baby aspirin is a better option. So I put all mine, when I find polyps, on a baby aspirin a day, a chewable, non-coated baby aspirin, because the coated ones sometimes don't get absorbed. Any disagreement on that? Surgeons.
I just say have your colonoscopy, and if you want to take an aspirin, you sure can, but don't take an aspirin and think you're not going to form a polyp and you're not going to need a colonoscopy. So
yeah, the true benefit of some of that stuff was seen in FAP, people who have adenomatous type conditions, or they have multiple polyps that occur. So I think it doesn't hurt anything to take a baby aspirin. It certainly has benefit for other things that we know of. So,
well, 20–30% reduction according to those papers. And the baby aspirin is better than the full aspirin. Now, you mentioned a familial type of polyposis. There's several different syndromes, is there not? Let's go over that quickly.
The one FAP, familial adenomatous polyposis syndrome, which is a mouthful, but that's an inherited form of polyposis syndrome where almost all those people go on to have cancer. They develop cancer. You usually find that at a young age. The other inherited form of colon cancer is something called Lynch syndrome, which is tends not to have as many polyps.
Yeah, but same amount of cancer, or a lot of cancer.
Right.
here's a relationship between cancer and diet. Is there any, well, we did talk about high fiber diet. What about cancer? Some people suggest fatty diet, right? I mean, what have you heard about a diet in preventing colon cancer? That less fat in the diet, do you ever recommend that?
Well, I think the high fiber and low fat diet is good for a lot of reasons, but again, there's you know, genetically and there's a lot of other factors that go into getting colon cancer. So I certainly wouldn't discourage somebody from eating a healthy diet, low in fat and high in fiber, but you know,
it's a minor issue.
I think it's minor. That's correct.
Okay. That's your take?
Yeah, I think it's multifactorial, you know, the reasons that we get colon cancer. I mean, certainly if you lose weight, I mean, people that are healthier tend to do better from that standpoint.
Don't forget to call us, 1-888-376-6225. That's 3-800-376-6225. From Brookings, discuss what constitutes a change in bowel habit. Is it the size of the stool, or is it a change in the style, or is it something? What about a change in bowel habit? Eric.
Well, bleeding certainly, and the number of stools, the consistency of the stool, I think would be the kind of the three most common things we'd ask a patient. And again, I mean, if you're trying to lose weight, if you're going on certain medications, there's a lot of reasons that your bowel habits may change. But certainly it's something that if it continues and you've noticed the change, is something to discuss with your physician.
Yeah, yeah. They talk about when you have rectal cancer, it changes the shape of the stool and all that. Have you ever seen a lot of that as a clue?
Yeah, a lot of people say that sort of thing. Mostly they say, though, that it becomes more narrow ribbon-like than, you know, that's usually
That's a bad sign because it's late when that happens. In 1966, Raquel Welch starred in a sci-fi movie called Fantastic Voyage. I don't know if any of you remember it. I do. In it, medical professionals were able to shrink down and actually travel through the patient's body. This is a fantasy, you know, through the patient's body to cure him in tiny submarine. Well, I didn't shrink, but I do have a way to travel through my patient's colons that may not be as glamorous, but it's just might help to save their lives. Through the years, I've made a lot of collections of recordings of different lesions. So these are old recordings, but we have an example of different kinds of polyps for you. The first example is the biopsying of a small polyp, probably 4 or 5 millimeters. That's smaller than the width of a pencil. And we're simply taking our alligator forceps down and taking a biopsy. The next lesion we have is a larger polyp and another biopsy. This is hanging down a little bit, almost like a pedunculated polyp, although not quite out on a stalk, a little larger than the first one. The third lesion we have is a biopsying of a larger polyp, probably 4/10 of an inch or larger, and that is the size that means we need to come back in 3 years. That is a size that we know has a significant risk of turning to cancer over a period of time. Now we see the colonoscope bending backwards, looking at the rectum. The colonoscope is the black tube coming through the rectum and turned around, watching itself from behind. There you see that there is inflammation around the rectum internally. And I believe that this ended up an inflamed area associated with a cancer. But it might have been an ulcerative colitis process. Certainly we see inflammation. Finally, this is a perfect example of an adenocarcinoma. It was growing about halfway around the lumen of the colon. It was shaped like bunches of grapes. And as we took biopsies of it, you can see where it bled readily. This is cancer of the colon, diagnosed by biopsy, and this colon lesion was removed by a surgeon the very next day. Now that turned out a little bit better than I expected. I was expecting to see myself standing in this colon, pointing at different lesions, but with the mastery of our producer, we were able to bring that to life, and it was good examples. Any comments that I stated that you think you would take difference or disagree or?
Would agree with it all.
Okay.
No,
yeah.
great.
Made a point. So certainly if you have any questions about colon or rectal health, send us an email at questions@oncalltelevision.com or give us a call at 1-888-376-6225. I have a caller from Aberdeen who said colonoscopies, what doctors can do through just do this? Is it just surgeons? Do any family practice or internists do them? And I'm a general internist. A partner of mine, a family practitioner, does them. The general internist an internist that turns a gastroenterologist does these, and the surgeons do these. Do the surgeons? I mean, what's your take? There's enough colonoscopies to go around, wouldn't you say? I mean, there's a lot of them that need to be done. Any?
No, I think my take on that is that anybody that's qualified to do it certainly can. Some of the data that we've seen is that you have to do X number of colonoscopies to be good at it, I guess, is the long and short of it. And the number that I've seen roughly is 200 plus. As you start to get over that number, then you start to be able to pick up those small polyps and be able to do the things that you need to when you do a colonoscopy.
Yeah.
So,
yeah, any take on that?
I would agree.
There was an article in the Annals of Internal Medicine, a group of about 35 or 50, I can't remember, gastroenterologists, right, pros, and they studied how they did their colonoscopies, how many cancers were found, comfort level, how many had side effects, how many ruptured the wall, because there's certainly there's always the risk. I mean, 2 out of 1,000 or 3 out of 1,000 or 0.8 out of 1,000, depending upon which study you read. And they found in this study that the very best scopes were done by the ones who took the time. Right. It was a time issue. And so it slowed me down when I was, after I read that article, you've got to take the time to look around.
yeah, there's a big push and a lot of data out there to suggest that you need to, what we call withdrawal time, the time you withdraw or you pull out from the end of the colon to where you're done, where you have to have 6 minutes or more, that shows that your detection rate or your ability to detect polyps increases.
Right. You're in agreement.
Right.
And so we've got family practice, internists, gastroenterologists, even surgeons can do this procedure. From Ramona, are upper GIs ever done with the colonoscopy, and how often and why? So make this point. Generally, we change scopes. We don't use the same scope. That was a joke. It's a bad joke. But yes, commonly I see that in my practice we'll do both at the same time under one anesthesia. What you guys?
All the time. Yeah, it's very common.
People present with blood in their stool. You don't know whether it's upper or lower. You can't always tell. You do one and then decide that you'll do the other one in particular if you don't find something bad in the colon.
Right.
The most important, they say, if you've got blood in the stool, the most important test would be which? The colon or the upper?
Well, it depends. If you're speaking of blood in the stool, the fecal occult blood test is different than gross blood. If you're seeing bright red blood, then colonoscopy would be the most important. If you see you're just anemic or you have positive fecal occult blood, then you would probably need both of them, because it certainly could be something from the stomach or the duodenum, and ulcer that would cause this also.
Yeah. Anything more on that, Eric?
No, I'd agree.
Then we have from Haleen. Caller had damage to her colon during a colonoscopy. Is there anything else that can be done for screening besides colonoscopy? Great question. What about other tests?
Well, there was a push for virtual colonoscopy and a kind of a sophisticated barium minimum steroids, I guess, and and it's hasn't really caught on. I think it's not a bad test. The problem with it is you have to undergo the same prep. Most people don't get the sedation that we give during the colonoscopy, and they still have to pump the colon full of air. And then if there is something there, you have to have a colonoscopy anyway. I mean, you can't do anything about it. So I think that's why it hasn't gone on. Now, certainly the regular air contrast barium enema is not a bad test, and there are times when we can't complete a colonoscopy, and that's what we generally order. And that's I think that's a good test for polyps. But then again, if there's something found, if somebody decides to have that done instead of a colonoscopy, if they do find something, then they need to have a colonoscopy. So I think it's unfortunate there are people that, for whatever reason, they have difficult anatomy, they have a difficult colon to do, and as I'm sure Scott would say, there are easy colonoscopies and there are difficult colonoscopies even for somebody that's very experienced. But for the most part, it's a safe procedure, and the perforations are rare. And that doesn't help this lady, but for the most part, that's a very rare event.
Right, so if a perforation does occur, and they say if you do enough colonoscopies, you're going to have it. That's all there is to it. We will all perforate a colon if you're doing enough of them. Even the two perforations that I've had were two of the perforations I've had were very tiny little biopsies. And then there was one that I thought it was a dangerous looking lesion, and I went after it and I'd cauterize it maybe just a little bit too much. So I've had 3 in many thousand colons, and I sense that it makes you better because you do it, but the fact is that people have to face the risk that there is a chance. And they say 3 in 1,000. Some studies, say 6 or 7 in 1,000. Other studies say 0.3 in 1,000. I mean, it just, and Scott, on that, what do you do if we do perforate the colon? That means putting a hole in the wall.
Right. So largely dependent on what sort of hole or what scenario we're dealing with. As you said, the most common cause of that is a biopsy site where you've used heat or some sort of energy to take that polyp off. These walls of the colon are very thin, and usually you cause an injury or a hole that needs to be, for the most part, resected or removed. That part of the colon has to be removed. Occasionally you can get a small pinhole from a tear, perhaps when the colonoscopy goes around and tears the colon away from the wall of the abdominal wall, which can sometimes be repaired just with a single stitch or something like that. By far and away, the most common way we have to treat that is to remove that part of the colon.
We have a cartoon of the resection of a colon lesion. I'd like to have it run right now, if you could, please. Lowell, could you put that up? Here it is. We're doing a scope method. Walk me through this, Scott.
Well, this is a laparoscopic colon resection, and as you can see, there's several small incisions that are made on the abdomen and instruments then that go into the abdomen that allow us to work and manipulate the tissue. You can see coming from the left side of the screen, there's a grasper or an instrument that can grab and manipulate, and an additional working instrument on the right side of the screen that helps us free the colon from the side of the abdominal wall. The idea is going to be to free the colon up and then ultimately remove the lesion and remove healthy tissue on each side of it, and then also we need to remove the blood vessels and the lymph nodes that drain from that cancer. And so I think what you'll see here is we divide the bowel on each side of the colon
lesion. Yep.
Mm-hmm. And then ultimately they should be able to put the two back together.
Yeah, they're showing a device that brings it together. Is this similar to the device that you use to put them together?
Yeah, this is the device that puts the colon and the rectum back together, really. There's other devices that we use to put the colon back together in other parts of the colon. But They're all interesting. They're all staples.
And this is a similar way that we would do the resection of a leak.
Right. Yes.
And is it hard to find the leak if there is a perforated colon? Sometimes you can't find the leak. Has that ever happened, Eric?
Sure does. I mean, it's nice to know going in where you thought the problem was. But sometimes we, a patient has some pain after colonoscopy, and we get an X-ray, and there's air outside of the colon, which means there's a hole someplace. And if the scope was an easy scope, but the person was taking out a large polyp on the right side, then obviously we'd probably concentrate on that area. But sometimes it is hard to
know where it's
know exactly where it is.
Yeah.
So.
Our on-call dietitian, Katy VanderWal, comes to us tonight with information that can help some prevent colon problems. The case for dietary fiber.
Eating a diet that is high in fiber has many health benefits. Following a high fiber diet can be beneficial for treating digestive problems. It is recommended that adults consume 20 to 35 grams of fiber each day. The average adult only consumes half of the recommended dietary fiber. There are two different types of fiber, soluble and insoluble. Soluble fiber is found in the carbohydrate of the plant. It does dissolve in water, and it can help lower your cardiac risk. It is found in foods such as fruits, oats, and legumes. Insoluble fiber is found more in the cell wall of the plant. It does not dissolve in water, and it's used more to treat digestive problems. It's found in wheat, rye, and barley. Tips for adding fiber to your diet include: eat plenty of fruits and vegetables. Fresh fruits and vegetables will have more fiber than canned or cooked. However, any fruits and vegetables will be a good addition to your diet. Choose your grains wisely. When you choose grains at the store, make sure you're looking for the words whole grain or whole wheat. Also look on the ingredient label to make sure that it says whole grain or whole wheat. Add beans or legumes to your diet in many ways by adding them to soups, salads, or to your favorite dish. When you add fiber to your diet, make sure you add it slowly and drink plenty of water. Adding fiber too quickly can cause side effects such as abdominal bloating and gas.
We've got some great questions. Thank you for calling. Here's from Beersford, or Beersworth. A 62-year-old caller doesn't have health insurance. Heard there's an assistance program. How did she find out about it, and how much help does it offer? And let's talk a little bit about costs. What did you say?
There's a South Dakota coalition that does assist in people that need colonoscopies, and I believe it's through the American Cancer Society. That would probably be the number I would give to go to find out.
Go to the phone book and find American Cancer Society. I remember doing colonoscopies in the good old days for $200 at the clinic, and that was it. We didn't have a lot of anesthesia, and you tried to get the whole way, and they'd grit their teeth. And then we moved to the hospital and got anesthesia, and the whole thing kind of skyrocketed. It's in the realm of $2,000 to $5,000, depending upon insurance and bargaining and all that, right? I mean, do you have any idea?
It's expensive.
Yeah.
But insurance covers, most of this. Most insurance companies will cover the screening portion, and certainly for therapeutic colonoscopies are covered. So.
Yeah, that's good enough, I think. Yeah. Here's someone who has an ostomy, a colonostomy, where the colon was brought out to the abdominal wall, apparently had rectal cancer or something down there, and so the bowel now comes to the wall of the abdomen. There's a bag, collects the feces in that manner. There are many people who have this that you would not know. There's a lot more people out there. But she's having some redness around the hole, and she's put powder on it, it's still red. Is there anything else to do?
Well, you're right. It's a common problem. There's many people that have colostomies and ileostomies, and skin issues, and appliance issues are a problem for a lot of people. And so we're lucky to have nurses that have specialized training in interstomal therapy. And they know way more about this than Scott and I.
That's exactly what I do. I refer to the ostomy nurse.
Well, they're just wonderful, and they, you know, I think that's where I have this lady start. I refer her there, and rarely can they not solve the problem. Sometimes even over the phone, but.
People are very fearful of a colostomy. Should they be, Scott? I mean, what's your sense on that? I mean, it's the worst thing in the whole world. I wouldn't have my rectum. I'd have a bag. Is that awful or what?
Yeah, I think I hear that a lot. For one, people are very fearful of it. The reality is, once they have it, they realize that most of the time, whatever condition they had before was far worse than having the colostomy bag or an ileostomy bag. And so most of the time, people are fine with it. In fact, if you look at the data, people who have colostomies or ileostomies, only a small portion of them ever get them reversed. So, I mean, most of the people are fine with it, and they end up just living with it the rest of their life.
Yeah, isn't that?
Yeah.
I mean, the people who've had ulcerative colitis or Crohn's disease or had problems, and their whole life has been a miserable trip to the can very often, that suddenly their life is back to them.
Absolutely.
It's an amazing thing, and you wouldn't know who has those things out there.
True.
Here's, explain the prep for colonoscopy. Now, you guys do the movie prep or the go lightly prep, sort of a tongue-in-cheek go lightly.
Or movie prep, right? Yeah. There's many different preps, and they've sort of changed over the years. They used to be high volume preps, where go lightly is really a relatively high volume prep, where you drink a liter of solution that causes your colon to become clean. As they've gone through the years and patient dissatisfaction, they've sort of decreased the volume and changed the concentrations and various things. So I use movie prep, which I usually do a split dose, which I have them take half of it the night before and then the half 6 hours before the procedure. I find that gives the cleanest colon. You know, the overall objective is to be able to see the entire wall of the colon and to make sure you don't miss anything. And so people don't like sometimes to take the prep at 2 or 3 in the morning, but when you explain it to them in those terms, they realize that, well, it's one time, one night, as opposed to not being clean and coming back doing it again.
It's the clean out, though, that's the hardest part, really, because once they get in there and they get a little propofol and they go to sleep and they wake up and they go, wow, that was a great nap. Any other comments about the prep?
I've gone to the split prep also. I think it's the best prep. I think it gets the colon the cleanest, and well, that's the idea behind it. I don't know. There's not, if anybody's looking for a prep that's not going to be a little problematic for them. I don't think that's out there yet.
No.
But
the Fleet's Phospho was taken away from us because it caused calcification in the kidneys and problems there, and it was too bad because it was a pretty good prep. But we've switched to mag citrate, which is kind of like the Fleet's Phospho soda, and that's different than the higher volume that you guys use. But we've been pleased with that in Brookings.
Okay.
Here is talk about hemorrhoids. What can be done about hemorrhoids, and what is a hemorrhoidectomy, and when does it need to be done? I've often told my patients to avoid them like the plague because, you know, there's that soft, mushy tissue back there that you kind of falls together and it controls the incontinence. And if you mess with it, it gets scarred tissue, and you have more problems. So, are you a quick hemorrhoidectomy type of guy, Eric?
No, I'd say the way I deal with it, I probably have 100 people I'll see with symptomatic hemorrhoids. Probably 90% of them will just handle in the office with rubber bands, and that's a little simpler way to deal with them. There are people that, for one reason or the other, do require surgery. It's a sensitive area. There's certainly some discomfort and some time off work, and it requires a general anesthetic to do the surgery. But for some people, that's the best way to deal with it. By and large, I don't know what Scott's feelings are about this, but banding in the office is how I'll deal with most of them.
Yeah, no, I agree. I mean, I usually categorize them into 2 types of procedures: the office-based procedures and surgical procedures. And I think by and large, the office-based procedures, we can handle most of them.
Okay.
As you said, the great thing about the hemorrhoids is they help control continence, and that's sort of your body's one of your body's main functions for hemorrhoids. And so that helps you start taking them out, and
You can get in trouble. I try to leave them alone, live with them. Some people say that there's a result of sitting on the can and reading too many, Sears and Roebuck catalogs or whatever it is that you're reading on, and sitting too long, pushing too hard. Do you think that has anything to do with hemorrhoids? Quickly, because we got a bunch of questions we want to dive into. Yes or no?
Well, I would discourage people from sitting on the can for long periods of time.
Okay.
That's where I put a plug for fiber, so you have your quick bowel movement and you're done.
Okay. Yeah. How about read that new studies show correlation between general anesthesia and Alzheimer's onset. Choices for anesthesia and anesthesia for colonoscopy. Have you heard anything about propofol? Have you heard anything about anything that might cause early Alzheimer's disease and anesthetics? Answer is
I would defer that to the anesthesiologist.
Yeah, I have not.
Yeah,
I have not. All I can tell you is it's nice not to be awake during some of these things. And the reality is oxygenation and blood pressure control is meticulously monitored during any procedure. Caller from Sioux Falls had more than 12 polyps, started on baby aspirin, hasn't had any more polyps. See? See? Britain, 5 days after her colonoscopy, she had blood in her stool. How common is this? Everything turned out okay, she said. So she didn't have polyps, but she had blood in her stool. I see that again. Eric, you see blood in the stool after a colonoscopy?
Well, yeah, she had no polyps removed?
No, apparently not.
Okay, all right. Well, I don't know if it probably could have been a hemorrhoid. It's just hard to know. I mean, it was bright red or dark. I don't know if that's real common. What do you think, Scott?
I don't know that's real common either. I think some of the, what I see is the hemorrhoids get inflamed from the bowel prep. That's one of the, that certainly could have been something along those lines. So
I see people, when I biopsy polyps, I generally hold the baby aspirin for 2 weeks. I know that many gastroenterologists do not, but I do in light of I had one bleeder that didn't need surgery or anything, but he bled a fair amount, scared me. Hold the aspirin for 2 weeks after your procedure. Caller took minocycline for acne and it messed up her bowels. She's on probiotics. Should she stay on these? How can she get her bowels back to normal? You have a comment about probiotics. You have a comment about tetracycline or minocycline for causing the C. difficile overgrowth infection.
Well, I think she probably needs to have a test for that. I mean, we do a stool take a stool sample in and see if there is a toxin for C. diff, and if that would be the problem, then she'd need to be on an antibiotic for a period of time. Now, all antibiotics will change the bacteria flora of the gut, and so a lot of them will, people have some diarrhea or change of bowel habits, but I think that's where I'd probably start with her, is have her see her physician and have him order that test.
Yeah. And that's your agreement. Okay, Rapid City caller, and I would make this comment. I've not seen minocycline cause it, but certainly when people start having diarrhea, it's worth doing the
certainly more prevalent than it used to be.
Boy, it's a terrible thing.
Hardly ever see it, and now we see it a lot.
One more reason not to take an antibiotic unless you absolutely have to. Have you resected colons because of people who've had C. diff?
Yeah,
had to remove their colons.
Yeah. People get sick and die from it. Yeah.
Don't use an antibiotic unless you absolutely have to. Don't use it for the cold, that's for darn sure. Caller has been constipated for more than, constipated, then had 4 to 5 loose stools in 2 hours. Does she need a colonoscopy?
Well, if she hasn't had one in a while, certainly
that might be
reasonable.
Yeah. Milbank, hemorrhoids, best treatment for itching rectum. Any comments about itching?
Well, I think just good perianal hygiene is probably the biggest thing. There are certainly some over-the-counter creams you can use if it gets real bad, but I think just, sometimes the hemorrhoids, most itching we see is just not caused by anything other than just the bad perianal hygiene. But hemorrhoids, if they're prolapsed and you have some sweating or mucus drainage from them, then that can cause itching, and fixing the hemorrhoids may improve it. But I'd probably first start just practicing better perineal
Or sometimes it's too much cleansing. I generally say cleanse with the Vani cream. and use that as a method. Well, we'll be back right after this.
Chug-a-lug, chug-a-lug, makes you wanna holler, hide-ho. Chug-a-lug, chug-a-lug.
A checkup for colon cancer isn't all that much of a to-do. A simple stool test may be all you need. But even preparing for a colonoscopy is a trifle considering the odds of getting the second most deadly cancer are 1 in 20. An easy at-home fit test or colonoscopy. Get screened, South Dakota.
Worldwide, more than 1 million people will get colon cancer this year, and about 1/3 of them will eventually die from it. Unless something changes, 5% of all babies born today will get colon cancer in their lifetime. It's the second most common cancer in women and the third in men. So how can we prevent or discover colon cancer early enough for a cure? When I started my training, an examination of the colon required a barium enema and was often followed by advancing a rigid 1-foot-long steel tube into the patient without anesthesia, positioned over a bent table with his or her bottom high in the air. It was an uncomfortable experience for the patient and the doctor, and it missed too many cancers. But things have changed with the development of fiber optic flexible scopes. Now it's almost like cave spelunking, where after running down to the end of a long cave, one backs out slowly, searching by powerful flashlight for stalactites and stalagmites. In reality, we explore the whole 5-foot colon while the image is exploded upon a large television screen, allowing the team to find even subtle and small, yet potentially dangerous lesions. Still, a vigorous and somewhat uncomfortable cleansing of the bowel is required, and then there are risks from that colonoscopy that follows. On the other hand, a gentle, comfortable anesthesia is provided during the procedure, and the risks are overwhelmed by the reward of discovering cancer early. In a review of 352 colonoscopes that I performed between 1999 and 2003, I found 164 people, or 47%, had polyps, and 8 people, or 2.3%, had cancer. Other studies have found that when a particular type of polyp, measuring greater than 0.4 of an inch, is removed, then that colonoscopy reduces cancer death risk by 40 times. Although it's important to have a colonoscopy when there are symptoms like blood in the stool or change in the bowel habits, a screening colonoscopy can discover cancers before they cause symptoms, and thus has a better chance of catching cancer early, before it spreads. I lost my father to colon cancer, and I have had 3 polyps removed from my own colon so far, so I'm sensitive to this issue. My next colonoscopy will be coming up in December. So when is yours scheduled? So we've got, a minute and a half to give them, what would be your soapbox, Eric? What would you say is, this is my take-home message for the night?
Well, I think, Colon Cancer Awareness Month is coming up, and I think we need to put a plug in for getting a colonoscopy if you haven't had one. And the prep's a little tough the day before, but the procedure, I think more people are afraid of that, and actually that's it's not an uncomfortable thing. We make patients very comfortable.
We need to do it, and we thank you. And we thank you. I sincerely thank our guests, Dr. Rolfsmeyer and Dr. Baker, for helping answer the questions from our audience this evening. Each week we look forward to the questions from you, our audience partners. Unfortunately, we run out of time sometimes to show all of them. So after the show, you can look at On Call to see what the answers are. Go to our On Call television site. And click on Archives button for the answers we couldn't fit in this evening. It may take a day or two to get them on the post, but your questions are important. We don't want to leave them unanswered. Well, it brings us to the end of our show this evening. Hockey great Wayne Gretzky knew procrastination is one of the most common and deadliest of diseases, and its toll on success and happiness is heavy. Or maybe artist Pablo Picasso had tonight's show in mind when he said, only put off until tomorrow what you are willing to die having left undone. Take care and stay healthy out there, people.
Funding for On-Call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubak and Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On-Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.